If we could start off by you just introducing yourself, so just saying your name, your college membership status, and where you practice.
Yes, certainly. So I'm Dr. Charlie Siderfin. I'm a GP, but I am a fellow of the Royal College of Physicians, and I live and work in Orkney, and I have lived and worked in Orkney for the last 20 years. And during that 20 years, I guess I've taken a number of different, I've had a number of different responsibilities. And for 15 years of that, I was part of the GP acute medicine team in the Balfour Hospital here, and was involved in setting up a system where we had a team of 6 GPs providing acute services within the hospital environment. And I think it was, well, I don't think, but it was because of that that I was offered my fellowship with the Royal College of Physicians. But in the last 5 years, we've had consultants, physicians working in the Balfour Hospital. And so I no longer work in the Balfour. I'm back into general practice. And so my role now is as a GP out in Westray, which is one of the outer islands of Orkney, where we have a population of about 580 people. And we cover Papa Westray as well, which is another island just 20-minute ferry ride away, where there are 80 people. And on that island, we have got 2 nurse practitioners who work 2 weeks on and 2 weeks off. And on Westray, I'm single-handed there. And we have nursing support there as well, with nurses, 2 nurses that work in rotation there, providing both community nursing and practice nursing. And the way in which we provide the GP cover on Westray is we work 3 weeks at a time, and there's 3 of us. So it's 3 weeks working on Westray, and then I work 6 weeks back in Kirkwall in my other role, which used to be lead GP for primary care here in Orkney. And then I was seconded to the Scottish Government to work with them around some issues around about the new GP contract and its impact on remote and rural, and also some work around about recruitment. I'm also the clinical lead for the Scottish Rural Medicines Collaborative, that's SRMC for short. And our remit is to look at remote recruitment and retention into general practice within rural areas. So that's kind of an overview of who I am.
Thank you. So you've touched on this already, but I wondered if you could describe in a bit more detail the hospitals or the premises in which you've been working. You said that there were multiple, obviously different hospitals or different sites you've worked in. So what sort of physical size are they? What sort of equipment do they have? What resources do you have?
So Daisy, I don't know, do you want me to talk about my work in Westray or my current work, which I've been doing for the last 5 years, or do you want me to talk about the Balfour Hospital, which is now not so current, if you see what I mean?
I think it would be interesting to focus on your current place, but if you notice any significant contrast, so in comparison to the Balfour, presumably you have less resources or less sort of equipment. So it'd be interesting to know a little bit of a comparison there, but focusing on where you are now.
Yeah, so the Balfour Hospital here in Kirkwall is is one of 6 rural general hospitals, of which Western Isles, Shetland and Orkney are 3, and then there's Fort William, Oban and Wick, which are the other 3 that are on the mainland and in part of NHS Highland. And the remit of a rural general hospital is to provide consultant support, consultant services around acute medicine, surgery, anaesthetics and obstetrics. And so within our rural general hospitals, we have a consultant workforce in those 4 areas. It also has CT scanning, ultrasound, that sort of thing as well, and laboratories to analyse bloods and do some microbiology as well. And I guess the hospitals are there to provide a service to the population, the rural and remote populations that surround them. And each hospital has a catchment area of around about 25,000 population. But of course, for me, when I'm not in Kirkwall and I'm out in Westray, that's a much smaller unit, of a very small single-handed practice where I'm on call 24 hours a day when I'm there providing that service.
Thank you. So you just mentioned, obviously, that you are 24 hours on call. I wondered if you could talk a little bit more about your sort of working routines at the moment. So what kind of commute are you talking about? What sort of working hours do you normally do? And the sorts of numbers of patients that you're seeing?
Sure. So when I start a shift, I take the ferry from Kirkwall out to Westray, and that's an hour and 20 minutes on the ferry to get out there. Prior to COVID, what we would do is we would arrive in the evening, and the GP that I was taking over, my GP colleague that I was taking over from, we would have a meeting together and eat together and talk about all our clinical cases. And then we would have the next day working together with the new GP coming in, taking over the surgery in the morning, and then we'd have a practice meeting over the lunchtime period, and we'd also do some training with the nursing staff as well. And then the outgoing GP would go on the evening ferry. So we had that overlap of 24 hours, which allowed us to provide continuity of not just care, but also, and perhaps more importantly, continuity of philosophy of care. That's how we look at it. So we have got clear understanding with as 3 GPs, although we are obviously 3 individuals, that our philosophy is the same, and how we ensure that is by working closely together. We take responsibility for all aspects of the practice. It's not just the clinical work, so that when you're on for your 3-week shift, you take that responsibility, and we keep in touch with each other by WhatsApp group or email, or now since COVID, we've got this wonderful thing called Teams that we use an awful lot, and it's really good. And so our handover now, rather than spending time together and the risk of infection transmission, what we do is we have a Teams meeting on the Sunday night before, and we have about 2 hours together when we discuss any of the patients, and so that we update each other, and we can have that opportunity to discuss patients that are difficult with each other and get a view on that, but also then talking about any administrative or other aspects of running the practice. So, for example, my 2 colleagues, one lives in Leicester and the other lives in York. So what this system has allowed for people to remain at home and to commute up and provide the service here. So when I'm in Westray, though, my commute is fairly short. It's to walk out the flat, down the stairs, and in through the back door into the surgery, because I live above the surgery. So there's rarely am I caught up in traffic on the way to work or on the way back from work. And I guess my working day normally starts around about somewhere between 8, 8:15, something like that, and will go on until at least 6:30, 7 o'clock, something like that. Normally I like to be out by 6:30, but it is a fairly full day. And that's around about a morning surgery and an afternoon surgery. Our morning surgery will run from 9 till about 11:30. Afternoon surgery will run from 3 till 5. And then in between, you've got home visits and other work. So I think people sometimes think, well, how on earth can a GP be that busy when he's only got 580 patients and another 80 on another island? And the answer to that is because the role of a rural and remote GP is so extended compared to what our urban colleagues would have. So we are needing to manage an awful lot more things. We often work as a social worker, providing support around about just trying to work out how we manage with people when they've got greater difficulties in the way in which they are needing to be looked after. We do an awful lot of work, I think, around mental health, but we also do quite a lot of extended work. So delivering what would normally be specialist services as a generalist. And we can do that by our relationships with our colleagues, normally consultant colleagues in other areas, being clear about what needs to be done for that individual and supporting them in their work there. So just to give you some idea around the impact for patients, if a patient needs to be seen in Aberdeen, for example, so a patient in Westray, if they're needing to be seen in the Balfour in Kirkwall, they would go in on the morning ferry at 9 o'clock, and they'd come home on the evening ferry at 6 o'clock. So that's how long a patient, a visit to hospital takes for a patient to Balfour. If it's to go to Aberdeen, which is our tertiary referral centre, it's 3 days. And that's because of the way in which the ferries and the flights to Aberdeen work. So for a patient to see a consultant in Aberdeen is 3 days. And you can imagine if they go down there and it's for a 10-minute consult to have their hands patted and say, thank you very much, off you go, that's pretty galling. So again, one of the silver linings of this black cloud of COVID is that Teams and near me consultations are something we've been working and shouting for at least 6-7 years, are now really become part of routine work. So that's been a real benefit to us. Yeah. And then obviously, whatever, that's our routine work in terms of the surgery. And then if there's an emergency that happens, then obviously that just drives a horse and cart through our workload. The surgery gets cancelled, it gets rescheduled as soon as you can, and you'll just need to deal with that emergency. So emergency care, whether that's, normally it's medical emergencies that will be the thing, but if there can be trauma or accidents, obviously that is our bag to sort out, and we sort that out, and it will take a minimum, if somebody's needing to be transferred off the island, then it's a minimum, absolute minimum of 2 hours before a helicopter will arrive. Sometimes it's 6, 7, 8, even longer. So our role as remote GPs in providing emergency care is an important aspect of the work that we do.
Thank you. So obviously you've mentioned sort of transportation in the sense of flights and in the sense of ferries. I wondered if there were ever issues around that. So if you are doing these, 3 weeks and then swapping with somebody else, are the ferries always regular? Is the weather a problem with that? Is that ever kind of become an issue?
Yep, it not infrequently does. I wouldn't say it frequently does, but I would say it not infrequently does. So ferries will get cancelled. You'll have ferries cancelled maybe for a 24, 36-hour period if you've got a big storm coming through. The planes, we've got small Islander aircraft, the 8-seater aircraft that go between Kirkwall and the islands, and they actually can often fly in weather that the ferries will be cancelled in. It will just depend on the wind direction. In terms of emergency medical evacuation, then the Scottish Ambulance Service helicopter will not infrequently be unable to fly because of the weather. And if that's the case, depending on what the situation is, then we may call in the Coast Guard helicopter to take patients out. But the rule of thumb there is that we'd use the Coast Guard helicopter if it's life or limb threatening. So, and I think, what you do as a GP out on the Isles is a lot of it is juggling and logistics. So a not infrequent question that I might say if we need to get something from Kirkwall, say, so we need some medication, does anybody, to the receptionist, to our administrator, who do we know that's in Kirkwall at the moment? Could they nip to the chemist and just pick this up and bring it in on the ferry? So it's about understanding where you are in terms of your with the regular transport. I had a guy on my last day out in Westray, and 8 o'clock he came to me in the morning, and he'd crushed his thumb and he had an open fracture there, and he was just covered in cow manure. He'd been crushed in the farmyard. So we had literally 3/4 of an hour to get things sorted out and to get him onto the scheduled flight, and that was by far the quickest way. But it was an awareness of when the flight was going. It was a couple of phone calls and making sure we could get him on there, and then thinking about what the ferry was as a backup. So a lot of our work is around about understanding the community, the logistics that are within the transport thing, as well as being able to utilize the support of the community when you have major things going on.
Thank you very much. So you've slightly answered this question already, but I'll ask it just in case you have any. No, it's not a complaint at all, but just in case you have anything else you'd like to say. So are there any challenges that you face which you think are more common for remote and rural practitioners, and also any solutions that you and your colleagues have come up with to those kind of challenges?
Yes, so Daisy, as I said I've been here 20 years now, and one of the things that I've been really interested and continue to be interested in is about recruitment and retention of GPs. And I'm also doing some work with the hospital consultants at the moment around that. And I think, so if we look at remote and rural general practice, then the role that we do that is different to urban, that is particularly different, is around about the urgent care. And we did some significant service redesign 10 years ago here. In 2009, we had been unable to recruit any GP to go and work on our outer aisles. And in 2009, all our GP posts within the outer aisles became vacant. So that presented us with an opportunity and a problem at the same time. And one of the things that we did is we went to the communities and we did some service redesign and replaced on some of the smaller islands the GP with a nurse practitioner. And that work with the community made me very, very aware about how communities are really worried about how they will get their urgent care. When recruiting, the one thing that practitioners are really concerned about is how they're going to deliver that urgent care. And so in 2010, I think for the first 5-6 years of what we called the Isles Network of Care, and I'll come back a little bit more about that later maybe, we did some work, a lot of work around about developing protocols about the management of emergency situations. We're very, very fortunate that we've got in Scotland, the Basics Scotland, which is a charitable organisation that specialises in the training of pre-hospital emergency care for primary care. And so we had that as a standard, and also attached to that or alongside that is the Sandpiper Trust. And the Sandpiper Trust provides bags, the sandpaper bags, which have got in it all the equipment that we require for delivering those emergency situations that we may come across. Over time, what we realized was, having developed the protocols, was that actually in our cars we had our sandpaper bag, and that was standard. It was set out in the same way in all our cars, but we had different ways of packing all the drugs and everything else that we would carry in our bags and so, in our cars. And so we have pulled together something which we called initially the Dream Bag, because it was a dream that we would have it, but it's now called the D Bag because it's got basically the drugs in it that allow us to deliver the protocols that we have developed. So what we now have is and what I am working on with this SRMC and with Basics and the Sandpiper Trust and the Scottish Government is to have it rolled out as a standardised system of pre-hospital emergency care across the whole of Scotland. So it wouldn't matter if you're a GP or a nurse practitioner or a paramedic, you went to a practice that was delivering pre-hospital emergency care. You could walk in there and you could be happy and confident that the Sandpiper bag would be there, set up in the way in which the Sandpiper Trust has laid it out to be set up. You'd have the protocols, you'd have the D bag with it all set out in exactly the same way. And also what we have here in Scotland, which we're so fortunate to have, is we've got the Scots Star, which is the emergency retrieval services that we have, which is the adult and the paediatric and the neonatal. And so what we would then have, we would have a network of primary care locations across the whole of Scotland where you could go and could know that you would have everything at your disposal. And you also would know what you need to do to train, which is to do the pre-hospital emergency care basics course and also the paediatric one as well. So I think, in answer to your question, I think the biggest issue for rural general practice is about the provision of emergency pre-hospital care. I think the second big issue is around about isolation. So as an isolated GP out on Westray with my nurse, I'm not as isolated as some because I have nurse support there. How can we address that? And so the other bit that we addressed with the Isles Network of Care was to link our 10 outer islands together with a weekly video conference call. And that has just revolutionized things. So through a 1 hour between 4 and 5 on a Tuesday afternoon, all the practices, all the 10 island surgeries practices come together, and we have this meeting where we discuss admissions, we discuss difficult cases, we discuss administration, we discuss as I was telling you, all how the bringing together of these emergency care protocols at the start. And through that, we've been able to develop the D-bag and everything else. And that's been a remarkably empowering thing. We still have our difficulties and our problems, but we are so much stronger. And in fact, what 2 years ago now, what I was really interested to do was to see whether or not we could scale that up, and whether what has worked here in Orkney, because what the Isles Network of Care did for Orkney was it transformed recruitment to such an extent that we've now got a waiting list of GPs that would potentially like to come and work with us. So it has completely transformed that. And I think the principle there is you need to identify what are the key problems, what are the key difficulties that are there, that are either stopping people coming and working with you, or are such a stress that it is really impacting on retention. And how can you address that problem? How can you build a system around that to support that? And so in the start of 2019, we set up a collaboration between Western Isles, Shetland, Orkney and Highland, and did a recruitment campaign called Rediscover the Joy of General Practice. And central to that was the provision of emergency care training with basics. We commissioned our own course for the people that we recruited. The idea about the training and the protocols and the sandpiper bag, as it was at that point. And we also brought them together in the recruitment weekend to bring them together, and then they also came together as a team whilst doing the pre-hospital emergency care course with basics. So these GPs work for periods of time, maybe only 12 weeks a year, and they might just come and travel up, and they are recruited from all over the UK. So we've got a disparate group of GPs that come from all over the UK, come and work in remote and rural locations, never, if ever, maybe a couple of times they have, working together, going to the same practice, but because they're in small practices, they tend not to be working together. But they come together on a fortnightly basis using Teams for their meetings, and they've got a WhatsApp group that keeps them together. And so this idea of bringing remote clinicians who are separate and isolated together using technology is a remarkably powerful thing, because it's not just and utilizing the work that you're doing to learn and to teach each other. But the other part of that is about providing the mutual support. So if you have a particularly difficult case, it's around about being able to sit down and say, this is what I did, and maybe I could have done this, and being able to get feedback from other people, and people asking questions. And did you think about doing this, Charlie? Oh, and I didn't think about that, but we could add that into our protocol. And did you get the protocol out, and did you read it through? And it's very supportive. So I think, and then the third thing that we found with the Isles Network of Care is developing flexibility around the contracts. So as I said earlier on, the fact that we work 3 weeks at a time in rotation means that my colleagues from York and Leicester, they can travel up and they can provide this. They can provide this service without having to relocate themselves and their families to Orkney. And that's worked really well for them. And that's how we've been running the Rediscover the Joy of General Practice. We recruited 33 GPs in that first year. And then last year, despite the fact that we were just going into lockdown at the time that we were recruiting, we recruited another 27 GPs. So, and that's in an environment where general practice recruitment is remarkably difficult.
Thank you very much. That was really interesting. I'm now going to entirely derail your train of thought by asking you about 20 years ago. So I was interested in, of course, you started work in Orkney 20 years ago, and I was interested in the change you experienced from your previous work, which I assume was on the British mainland. What did you feel when you came up to work in Orkney for the first time? What were the contrasts to your experiences? Not just in terms of equipment, but also, is the relationship between the doctor and the patient, does that seem different in somewhere like Orkney?
So Daisy, you should never make assumptions. So and so I'd always wanted to be a remote practitioner. That was my big thing. So my career has always been aimed towards achieving that. So I was really fortunate initially to get a job for 3 years with the British Antarctic Survey, and I spent 18 months in the Antarctic. So that kind of really focused my mind around about how you provide remote services and the amount of planning and I think a lot of the stuff around the way the surgeries within the bases were set up. But the base where I was one with the aeroplanes, and we were putting scientists out into the deep field, and they may be out for 2 or 3 months. So I had a medical book, and I did a revision, a new edition of the medical handbook for the British Antarctic Survey, and I did some work around telemedicine, and that was nearly 30 years ago now. So that was the first thing, and then I came back and I finished my training. I did my medicine, and then I did my general practice, and then my next plan was to go to Africa, and my wife and I went to Africa with 2 children and worked in a remote and rural hospital there for a year, doing the whole gamut, everything, cesarean section, surgery, medicine, and working in an environment where a third of our women in antenatal clinic were HIV positive, where you have malnutrition and where you had malaria as well. So that was a tremendous training for me in terms of developing the skills and the skills and the thought process which you need, and your attitude to providing rural health. And then we went from Africa to Australia, where I was a single-handed GP, with the nearest GP to me 100 miles away and a 17-bedded hospital of my own to look after. So coming to Orkney was like coming to the metropolis. I couldn't believe what facilities we had and what support I had. So, but I think that but to answer your question as to how maybe things have changed in the 20 years that I've been here, I think one of the great things about Scotland is Scotland has really invested a lot of time and thought and effort into the provision of rural health to our rural communities. And when I first came here, we had the RURARI Remote and Rural Research Initiative. I can never quite get that bit, but a huge amount of work and thought went into that. We then had work setting up the rural general hospitals and establishing those. We ended up doing a lot of work around tele-education and setting up the mobile skills unit, as well as the creation of REAL as the remote health. REAL. We'll have to chuck something into this. I can never think what REAL stands for, but it's the rural aspect or the rural side of NHS education for Scotland. So it's focused upon what are the educational and the service needs of rural health. So a huge amount, and we've got the Scottish Rural Medicines Collaborative, which I'm clinical lead for. So that, if you like, has been a progression. And I think over this time, we've learned a lot as a nation. And I think we've got a lot. During this time, the emergency medical retrieval services were set up. I mean, what an amazing boom that was. And there's a much clearer understanding of what are the roles and remits of our rural practitioners. And when I say that, I mean, both our practitioners within the hospital environment, those within primary care, the GPs, the nurses. It's about a multidisciplinary team, isn't it? That's the key bit. And I think that over this 20 years, I think we have strengthened and recognized the benefits and the strengths of the multidisciplinary team. And what we've also seen is we've seen a tremendous explosion in the technology that's supported us to do this. So during the time that I was working within the Balfour Hospital, providing acute medical services there, we did some big trials around the use of telemedicine for the provision of pediatric care, for example. When you've got a very difficult pediatric case in the hospital, how do you manage that? Being able to bring in a consultant from PCIU to look over your shoulder and to actually help you as you're working, managing and resuscitating a child. I mean, it's an invaluable support. And now that we have got the technology, and this is one of the huge benefits that COVID has brought us, the fact that it is ubiquitous, that Teams, we would be working and trying to get the centre to understand the importance of having video conferencing at meetings, and you could never really hear it. Whereas now, everybody's on Teams, and it's so easy and it's so straightforward. So these things have changed very dramatically, and for the better, I believe, over that 20-year period that I've been here.
Thank you very much, and I've learned not to make assumptions now. So another thing I wanted to ask you about was the medical complaints that people are coming to you with. Are there particular medical complaints that are more common on Orkney than they might be, say, on the British mainland or in less remote and rural areas?
So I think, it's really difficult for me to judge that, bearing in mind that I've been here for 20 years, and therefore that becomes obviously for me the norm. And we're having, the 3 years previous to that, having worked 2 years in Australia and then in Africa prior to that. So it's difficult for me to know what's normal, but I do think that we have one of the visiting consultants providing outpatients will always comment on how interesting and diverse the pathology is that comes into their clinics. So, for example, I think when I first arrived here, I noticed there were a lot of people with hypothyroidism. That just seemed to be disproportionate to where I'd worked before. And there certainly seems to be a presentation of some rare diseases. It seems to be greater. And I think patients often present maybe slightly later than they might in an urban environment. I think the stoicism of Orcadians may contribute to that. And I do wonder whether, because the genetic pool within Orkney had been narrower, whether some of the illnesses that have got a recessive or a trait genetic characteristics to it, whether that is part of the reason why we maybe see some things more. I remember phoning a consultant up in Aberdeen and saying that I had a patient that I thought had a pheo, and he said, well, send him down, and this, that, and the other. And then I sent him down, and he phoned me back, and he said, a few days later, he said, yeah. He said, you are absolutely right, it was. But the most remarkable thing is we've got 2 other people on the ward at the moment that have got a pheo as well. This is a remarkably rare condition. And yet there were 3 from Orkney on the ward all at the same time.
Thank you. So sticking with the patients for the moment, I was wondering if there are any particular challenges patients face in Orkney accessing treatment or maintaining treatment, given what you said about distances and things, or even other aspects of health, such as staying healthy and active, for example.
So I think I'll take the last bit first. So staying active and healthy. One of the things when I first moved here was I would be in the ward and I'd see somebody and I'd chat to them and clerk them and bring them in. And then I'd go back and write up their notes and realise that they were in their late 80s or early 90s. And I had no idea. I thought they were maybe in their late 60s, early 70s, something like that. And I started to look at them and think, what is it that makes these people so young of mind and so fit? And my conclusion about that was that they had worked, these are indigenous Orcadians, they had worked very hard over their lives. They had been in often very hard physical manual work, but or not necessarily always manual, that their diet had been a pretty limited diet, but a healthy diet. And the third thing that I think that made them so young was that as a community, they were still and very actively involved in the lives of young people. And so many Orcadians, and because we are a close-knit community, because we do go to functions together, we don't obviously at the moment because we're in the midst of COVID, but my children, I've got 3 boys that have grown up here. They're no longer children. They're 20, 23 and 25, but they grew up to know how to talk to adults, to talk to people in the community who are in their 80s, because these people were at social dues that we were at and were interested in them. So I think I think in terms, and we have a lot of sport that goes on here, and a lot of interest groups, around about arts and crafts and all sorts of stuff. It is a very active, and music is a very big thing, traditional music, but any kind of music. So there's lots and lots of stuff that goes on, and I think that keeps people's mind healthy in mind and body as well. And lots of sport, whether that's track sport or football or team sport or sailing or whatever. There's lots going on, and the biggest problem as a parent here is being able to get your children to all the activities that they want to go to, and get to some yourself. So I think we're very fortunate in that way. But I do think from a health point of view, in accessing health, there are real issues. So I've told you about what it's like for somebody to go from Westray to Aberdeen, for example. And previously, up until about 7 years ago, we didn't have a CT scanner. So getting a CT scan had been a big issue. If you need to get an MRI now, we don't have an MRI here. So you have to access that in Aberdeen. And any other, obviously, more specialist areas, then there is travel that really makes that a big issue. When I was working in the hospital, I always found it really useful, and this is really a reflection on what's now called realistic medicine, but I found it really useful that we had a stretch of water between us and Aberdeen, so that if we had somebody who was maybe elderly and unwell, and I would speak to them or to their relatives if they were unable to speak, and say, I think that we may need to have to think about a transfer to Aberdeen. Now, if we transfer you to Aberdeen, these are the things that I think Aberdeen can provide for us, for you. These are the investigations they can do. This is the specialist care that they can do. And what I want to ask you is, do you want to go to Aberdeen? And is that what you want to have? Or would you like to take your chances and stay here with us? And often, I would say maybe 7 to 8 out of 10 people would say, if it's all right with you, Charlie, I prefer to stay here and take my chances and perhaps die with my family around me and my community around me. And I think that I loved that aspect of working, and I still love that aspect of working, of being able to be clear with individuals about what it is that they want for their lives, whether for them being here and being looked after here, whether that's more important than actually maybe getting the absolute top whack of investigation, and I think that's an important thing that we need to talk with our patients about. And so, yes, they are rural patients are disadvantaged. In many ways, Orkney isn't as remote as some other places. If you think about somewhere like Stranraer, with how many miles and hours of driving it takes to go from Stranraer to Glasgow to get your second opinion. At least here, you only have to go to the airport and get on the plane, and it's an hour. It's a lot of faff, and because of the timetable, it may take a day or two, or if you're in the outer islands, 3 days. But so there is, for you to get your health, you do need to be prepared to invest the time into getting your health, and you need to be able to travel for it. Again, though, I can't emphasize how I think things have really changed with Teams and Near Me, which is the NHS version of video conferencing. And I mean, over the last 10, 15 years, we have been running video conferenced clinics. So neurology were one of the first from Aberdeen to provide a neurology service where patients would come into the Balfour and then see the consultant neurologist over VC. Been doing it with diabetes for a long time as well. But I think that's going to now become more common, and I think therefore that will be to the huge benefit. And from our point of view, from a GP, for example, I was out on Westray for a month over Christmas. And so I was involved during that time with having a near-me consultation with an oncologist, with the patient and the patient's husband, and being able to go through with them and understanding what the nuances of their diagnosis was and their treatment plan, and being able to then support them through that treatment plan. So it's the opportunity for us to provide a holistic care. And I think patients, as a result of being in the smaller communities, their access to their GP, their access to a real personalised care is much greater. And I think the job is a really satisfying job for any rural practitioner because of that continuity, because of the breadth of the work that we do, because we're always challenged about how we maintain our skills and competencies, but not just that, but how we have to utilize the logistics of things to allow that care to go ahead, whether it's knowing the ferry timetable or calling in the Coast Guard helicopter at 3 a.m.
Fantastic, thank you very much. So I've asked quite a bit about your sort of personal experiences. I want to take a bit of a step back now and ask sort of bigger picture questions about what you think about the remote and rural medicine. So firstly, are there any particular skills which you think are particularly important for remote and rural medical practitioners, more so than, say, on the British mainland?
So I think emergency care, whether that's within the community or within hospital, that is something that you, as a remote practitioner, you'll get more involved with within a rural area. So within the hospitals, obviously, when working in the hospital, if there's a trauma that comes in, that doesn't just go to A&E and get dealt with by the trauma team. It gets dealt with by a team of generalists providing that service. So I think emergency medicine and trauma are things that we need to be well trained in and involved in. I'm sorry, Daisy, there was something else there that was definitely I was going to move on to, and it's completely slipped my mind. Can you just tell me the question again, which was?
Are there any particular skills which are particularly necessary for remote and rural practitioners by comparison to those on the British mainland?
I think the other is about being a broad generalist. So you don't need to be a specialist, but you do need to know who you can get in touch with and how you can get the support of the specialist with that knowledge that you need and how you can then deliver it. So I think skills around about your personal interactions, your ability to network with people, to develop relationships with people, whether you're on the phone or by VC or whatever, but people that are remote, I think being a networker is really important. And I think the other thing is you need to have a can-do attitude. So it's no good being a remote practitioner and saying, actually, all I do is I don't do that. I do this, but I don't do that. And therefore, I'm just going to send that away and somebody else has to do that. I think if there will be things that you don't do, but it's about being able to recognize that actually you may need to learn to do that. You may need to learn to do that by phoning somebody up and asking for them for their opinion and their support around about that, and then delivering that care yourself. So I think you need to be a very broad generalist. I think you need to have the attitude that you're there to provide a service and that you will learn how to do that. And I think you need to be able to have the ability to make strong relationships with your colleagues, both locally and distant to you, so that you can actually deliver that, gain their knowledge, their experience, but also to utilize them as part of your own resilience. So, being by yourself and having responsibility is a big thing. And whether that's in primary care or it's actually within the hospital environment where you may be the only physician that's on over the weekend, you need to be able to manage that isolation and develop ways of being able to support yourself in that. I think it's also important to have good hobbies so that when you're not in work, you've got other things that absorb you and take you out of your work.
Thank you. So there are, of course, some fairly sort of significant current events happening in the wider world. There's, of course, Brexit, there's COVID, there's the potential for Scottish independence. Do you think any of those things will affect somewhere like Orkney differently to the way it will affect the British mainland, either more or less? Well,
I'm a self-confessed irresponsible optimist, all right? So you'll have to take everything I say with a pinch of salt. But I think COVID will bring us benefits in terms of our recruitment. I told you already around about how it's brought benefits in terms of remote working and how that's given us tremendous opportunities to look at the way in which we're delivering care. During the first lockdown for the first 6 months, I set up and ran the COVID Assessment Centre here in Kirkwall, and just seeing the way in which we work there and thinking about how we can utilise those working practices and how we can maybe adapt some of that working ways of working to be able to provide urgent care to our patients. What a tremendous opportunity. And also the way in which it's just completely changed the way that we behave and think about things, not just people in medicine, but for the society in general. So whereas before people would have expected just to go and see their GP and walk in and see them, they now accept a very different method of care. So with that, we've got tremendous opportunities to change the way we work. That's not to say that I think all remote consulting is the way forward, far from it, but it gives us an opportunity to think differently about the way in which we do that. In terms of recruitment, I think there is some early evidence that it's the case that I think a lot more people are interested in moving and working in rural areas where the population density isn't so great. I think as a society and as individuals, we've spent a lot of time thinking about what's important to us, and maybe the things that were important to us a year ago are slightly less important and other things are important now. And I think that some of those additional things you can maybe have better chances of being able to get in a rural environment. I think Brexit is, in terms of recruitment, it will be an issue, and as I said, the work that I was doing with Scottish Government was around recruitment, and I continue to do that within SRMC. And of course, there's an impact. We're no longer in the EU, and therefore there is a whole lot of other regulation that we need to think about. But again, every problem has got an opportunity as well, and I guess there are opportunities around about thinking about how we can recruit, and most importantly, I think, to support other nations as well. And I think that's something that I really admire in Scottish Government is our commitment not just to looking after our own needs, but also thinking about how we can support some of the poorer countries and how we can utilise the skills that we have. Because one of the great things about the provision of rural care is that it gives, I think, some of the structures that we develop gives us great opportunities to utilise those structures and that way of working in a different environment, maybe thinking about the delivery of medicine in developing countries and things like that. Tremendous opportunities to be able to utilise expertise in a different way through IT. Scottish independence, well, I'm English, as you may well have picked up from my accent, but I think Scotland and England have got I think our healthcare systems have diverged quite a lot already. I think Scotland has got a collaborative way of working, and I feel very privileged to work within NHS Scotland. The fact that if I want some support from somebody, I can phone somebody equally in Shetland, or I could phone somebody in Grampian, or I could phone somebody in Glasgow or Edinburgh, and I would be pretty confident that they would give me support and they would give me advice. There wouldn't be any charging. There wouldn't be any question about whether we got an SLA with them or not. That makes the biggest difference to me in terms of that collaborative attitude to things. And what we have shown through Rediscover the Joy of General Practice is that collaborative recruitment, which initially would probably appear to most people to be completely counterintuitive. Why on earth would I want to recruit for somebody else's vacancy when I've got problems of my own? Well, the answer to that is if you can get a practitioner matched to the job that is really the job that is for them, then they'll hopefully stay there and they'll keep that vacancy filled, and therefore that's one less person you need, or one less vacancy that you need to work against. But together I think we are so much stronger. So I don't know. Clearly there'll be, if Scottish independence were to come about, there would be some significant challenges that we would need to address, but I think there would be a number of opportunities as well. So it's the optimist in me, as always.
So sticking with the optimism, sort of as we wrap up, I just wanted to ask, imagine if, money was no object, there was all the money, there was all the resources you could dream of. What changes under those sort of circumstances would you ideally like to see in medical provision in Orkney?
Well, you see, Daisy, that way of thinking is so foreign to me, because we always work within we always work within a limited budget, and that to me is actually quite part of the joy of it as well, which is about not thinking about how you throw money willy-nilly at something in order to sort it out, but actually what you do to be able to make it work. So coming back to rediscover the joy, we were very strong in our values. So our values were those of NHS Scotland: care and compassion, dignity and respect, teamwork, quality improvement. But we also spoke about the need about, if you're going to come and join one of our rural GP support teams, that where if you went out to practice, you were there to support, to deliver the medical care, but also to deliver all the other functions of general practice that are required of a general practice. So stories of locum GPs charging enormous sums for a day's work and then saying, oh, and by the way, I don't do home visits and I don't look at letters and I don't look at results. That's, to my mind, is totally unacceptable. You get paid to do a job, and you need to do that job as complete. So, sorry, I'm not answering your question as to what would I do. What would I do? I think interestingly, some of the fundamental infrastructure within our rural communities would be one of the first things that we'd need to address. So things like transport, making sure that your housing and your communities are supported to be able to be resilient and secure in themselves. Those are things I think that are really important. And if we have those things in place, then being able to recruit to that and being able to support our practitioners. So I think what makes practitioners happy in their work that they do is if they feel valued, if they feel they're doing a job that's worthwhile, if they feel that they're making a difference. And within health, there's very much about the relationship that you develop with your patients as well. So I think what we've shown here in Orkney is that you can do all of that, and you can do it on what you might feel like a part-time rotational basis. And you can continue to have all those benefits, but that's about attitude, and it's about understanding clearly what you as an individual want and what maybe your colleagues want. I often think about what were the idealistic reasons why I went into medicine in the first place. What was it that drove us? What were we expecting that we would do when we were at medical school? And have we maybe moved away from that? So what I would like to be looking at is I'd like to be looking at what are our values? What are the values of the profession? What are the things? How do we connect individuals together? How do we make ourselves stronger by being a part of a whole rather than being individuals fighting for our share of the pie? And I think that when we work like that, and when we empower our clinicians to lead in service redesign and in service development, in the delivery of the service, and when they are supported by their managers, then I think then we've got real opportunities. Because actually, sometimes I think managers think that as clinicians, we're always wanting more money or we're wanting more resource. But actually, you know what I found really interesting about the whole COVID pandemic is that clinicians quite often got really upset and annoyed when resource was utilized and wasted. They weren't actually saying, oh, we need more of this. We're saying, actually, surely we can find a better system to deliver that more effectively and more efficiently. So I don't think necessarily money is always the way. I think that sometimes being able to work to focus on our values, to focus on our patients, to focus on the things that are driving us as individuals. And if we can allow that to come to the fore, and if we can allow ourselves to be aligned with our values and with the values of our communities, that I think is the way forward for remote and rural. And I think there's an adage that somebody in Highland said many years ago, and continues to say, and we all continue to say it as well, is that if things work in a rural environment, they're almost certainly work in an urban environment. But the reverse is not necessarily, and quite often is not true. So I think that one of the great things about rural and resource is part of the reason why it works so well. So the lack of resource makes us very inventive, makes us innovative, make us think around the outside of the box, to think around a problem. How do we deliver this? How do we do that? So I don't want to call a helicopter. I want to put somebody onto the transport if that's appropriate. I want to think about how I find the best for my patients at the most cost-effective way, so that we utilize our resources effectively as we possibly can.
Thank you. So that was my last question. So before we wrap up, I just wanted to ask, is there anything that we haven't covered that you would like to bring up at all?
No, I think probably you're giving me the opportunity to stand on my soap or sit on my soapbox and say all sorts of things. I just personally, I think remote general practice, remote medicine is the most rewarding, most remarkable job that there is. And that's because I feel that I'm embedded in my community. I'm part of that community. I'm seen as a doctor, but also as an individual, as a father, as a husband, as a member of the community who's maybe sailing very badly. And, you know, and it's lovely to be part of that community and to have that diversity of work. So no 2 days are ever the same. It's hard work. You have to work very hard, but it's very satisfying and rewarding work. So that's my final plug about rural practice.